Welcome to the Codecast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the 121st episode of the Codecast Podcast today. My name is Terry Fletcher, and I'm going to clarify and say welcome to February. My episode last week, I can't believe I said, looking at my wrong calendar, and I said welcome to March, but only one person caught it, and when I listened to it on playback, I was like, okay, what month am I in? So yes, we all lose our minds a little bit fighting this flu for the past week, and so I'm going to ask that you give me a little bit of a pass there. So hopefully I'm on the mend, and just bear with me. I have turned up my audio, and hopefully it'll be kind to me today, but I'm going to be stop and starting a little bit here just because I don't want to get a coughing attack on air. Today, the Codecast Podcast is brought to you by Keck Medicine of USC, over 500 internationally renowned doctors at a leading academic medical center, keeping you healthy, on track, and doing the things you love. The Keck Effect, Los Angeles, California. So today our subject is going to be on errors in coding and billing. I'm also doing a Talk 10 Tuesday that has some of this information in it as well. But I have seen so many errors lately. I wanted to just bring you some insight on that just to make sure you weren't also making some of these mistakes that could be costing you major revenue and also potentially an audit if any payer would look at your mistakes as intentional. So we have to be very mindful of that and careful that it's not becoming a kind of an epidemic within your office, I would say. I just got off the phone with a healthcare attorney with a client of mine, and it was interesting just in some of the things we were talking about with some non-compliance issues at the practice. And it's almost like beating a dead horse or hammering it into your physicians that there are certain things that are not allowed. And it's not just with your physicians, but it's also with coders, with billers. And there's some laziness that goes on. I won't sugarcoat it here, folks, but there are some basics, and I don't want you to be guilty of some of these mistakes because, again, it can cost your practice millions of dollars in lost revenue. And the compliance concerns are just kind of ridiculous. So let me just kind of explain some of the things that have been happening lately. So the random use of modifiers. Now we know that modifiers, because I have that spotlight series I do, those are 2-digit codes added to a service or procedure, and it tells the payer of special circumstances. So we know the AMA develops CPT modifiers, which are numeric, and then Medicare and Medicaid, so CMS, develops HCPCS modifiers, which are alphanumeric or alphabetic. And you can use both types. But why would somebody randomly apply a modifier? Well, maybe there's a misunderstanding, or there's incorrect information, or there's just a desire to get the claim paid, just to name a few examples. But for both compliance and revenue reasons, correct use of modifiers is critical. Using modifiers requires an understanding of the global surgical package as well, which that's one of my coding questions today that I'm going to talk to you about. But there's several good coding books on the market that exhaustively explain modifiers. I have one as well. So make sure you find one of those because modifiers are really your key to reimbursement. And I've seen a lot of incorrect use of modifiers, not only from an error perspective, but also from a revenue loss perspective. Next would be selecting the wrong procedure code. So with more than 75,000 CPT codes, it is easy to select an incorrect procedure code. But sometimes the source of an error is usually not confusion about the procedure performed. Incomplete or inaccurate code descriptions on encounter forms, something that you may call cheat sheets, I hate that word, and electronic charge systems are really where the significant sources of errors are starting to fall from. So failing to read the editorial comments at the start of the section in the CPT book or the notes near the code is another cause for this type of error, and not reading specific coding companions available to assist in special circumstances. One of the biggest errors I see is in cardiology. You know, that's my number one specialty. And so this happens quite a bit where a doctor does a heart cath and then moves on with an intervention. And either the heart cath is not billed because whoever the coder is says it's inclusive of the intervention, which is not true in all cases, or it is billed when it shouldn't be billed because it's for setup angiography and not diagnostic. And so understanding the language prior to what it says in CPT about interventional procedures, and I mean stents and angioplasties, and a way to open up that blockage in the vessel. What it says about that and when you can and can't bill for that heart cath is going to make a difference of $300 to $600 for your physician, and also a compliance situation. And so selecting the wrong procedure code can be costly. Failing to link diagnosis codes. So this is a huge issue, and I see this probably more than anything when I audit. So I'll see a patient come in for a pre-op for something, and then I'll see something like an ankle fracture diagnosis. The CPT and HCPCS codes, that tells the payer what service was performed, but the diagnosis code tells the payer the reason for the service. So some patients present for more than one condition, then may require an unrelated service, and other patients may receive a service that's only covered for a specific indication. So for example, let's say a patient presents to a family practitioner for hypertension, but has a wart destroyed during that same visit. So the code for the office visit must be linked to the hypertension, but the code for the wart destruction has to be linked to the diagnosis code for warts. And most often only one diagnosis is listed or linked, and then denials happen, or you can't show medical necessity for why you did something, and you have to have that link. And so make sure who's ever in your system applying the code sets understands that linkage. Otherwise, it could really cause for denials and appeals, and the process can be very expensive. Now, one that comes up quite a bit, and this is a compliance issue, using a nurse visit in place of another service. So some practices still believe that they can charge a nurse visit with an injection or a venipuncture to draw blood. And I've heard this phrase all the time, quote, because our nurse takes the patient's vital signs. Okay, or they ask, can we bill a nurse visit with a flu shot? Well, who cares that you're taking vital signs? It's not medically indicated. Nurse visits are bundled into injection codes, should not be paid separately by a payer using NCCI edits or proprietary edits. And as far as the venipuncture, the practice motivation is that the nurse visit pays more than a venipuncture or blood draw. But this doesn't accurately describe the reason for the visit or the service performed. So if the reason for the visit and the service performed was venipuncture, then that's what you bill. There's 36415. If the patient presented for an allergy shot, bill for the administration of the allergen. Assessing the pre and post shot is part of the payment for the administration of that planned injection. So try not to overcode those things, because that can be just a huge compliance issue, and also audit, or I should say flag you for an audit in the future. Now, the next problem I'm going to mention, I'm sure some of you are going to say, oh my gosh, I wish my doctors could listen to Terry on this. It's called not keeping up to date. So medical practices and hospitals are understandably cautious about budgets, but failing to keep up to date on new coding rules and initiatives, this is an expensive mistake. It results in lost revenue and potential compliance risk for practices. I see many practices pouring hundreds of thousands of dollars into EMRs and new medical diagnostics, but when I ask what their coding education budget is for the year, rarely do I hear more than $1,000. And that's usually a practice that's ahead of the curve. As a healthcare consultant, I find myself in more practices with coders using dated code books, referencing outdated material, and not having the financial resources to bring their staff up to speed on current rules. And so you have to make sure you've got budgets to make sure that they are educated, that they're updated. I appreciate that the Codecast for you is free, but then you need to say, okay, we're comfortable with this person, with what she's telling us on this platform, but we need to go take a webinar. We need to get updated on things that happened this year. It's now February, right? Well, I'm still seeing people saying, what about the myocardial strain code? Can we bill for that? That code became effective January 1st. I still have practices saying I'm getting denials on consultations when I bill a consult code to Medicare. Okay, people, Medicare did away with consults in 2010. We're now 2020. So there are things that have to be updated, and the only way to do that is to be educated and make sure that the dollars are there for education. And if you think I'm on a soapbox about this, you better believe I am, because I think that one of the ways to make staff not have success in their position and at their job is to not have them trained properly. So for the office managers, for the practice administrators, for the physicians listening to this podcast, you need to find the budget to make sure that you have educational resources for your staff. And when it comes to medical coding errors, they fall into broad categories: fraud and abuse. And the former involves intentional misrepresentation. The latter means the falsification was an innocent mistake, but nonetheless representative. And so the AMA has a book called Principles of CPT Coding, and it's a 9th edition. And an example of abuse could involve coding for a more complex service than was performed due to a misunderstanding of the coding system. And unfortunately, you're going to have some payers that don't consider this a mix-up. They consider it an egregious error, and it can come back to really hurt your practice. So some of the things that they talk about are unbundling codes. So when there's a single code that's available that exists that captures payment for the component parts of a procedure, that's what should be used. So unbundling refers to using multiple CPT codes for those parts of the procedure, either due to a misunderstanding or an effort to increase payment when you know it's really inclusive of a certain service. Another one is upcoding. Say a physician meets for a few minutes with a patient about a routine question, but the coder bills for a full exam lasting 45 minutes because that's what was checked on the charge capture form. That's a complete no-no. Often this is what happens, and these are considered upcoding. But sometimes they are this blatant, and the consequences have been very severe. And a psychiatric physician that was fined $400,000 and permanently excluded from taking part in Medicare and Medicaid, in part due to upcoding. He billed for 30 or 60-minute face-to-face sessions with patients, when in reality, he was only meeting with patients for 15 minutes to do medicine checks. And he came to me after the fact and said, "How can I fight this?" And I'm looking at his paperwork going, "You're not going to be able to fight this, but let's see if we can, basically minimize it and educate you so it doesn't happen in the future." And then failing to check CCI edits when reporting multiple code. The National Correct Coding Initiative edits, so they were developed by Medicare to help ensure that correct coding methods were followed, helping providers avoid inappropriate payments for Medicare Part B claims. So these are automated prepayment edits. They are reached by analyzing every pair of codes billed for the same patient on the same date of service by the same provider to see if an edit exists in the NCCI. So if there is an edit, then one of those codes is denied. So let's say, for example, you bill a lesion, excision, and skin repair on a single service date. But CPT coding guidelines say simple repairs are included in the excision codes. So separately coding the repair would be wrong and generate a CCI edit. But if the repair was performed on a different site from where the lesion was removed, is it okay to bill for both? Yes. And append a modifiers to let the payer know that the procedure was indeed a separate excision or from the original excision? Yes. But you have to be careful with that and know your rules. Another one would be improper reporting of the infusion and hydration codes. These are time-based. Good documentation of the start and stop times are essential for medical coders to properly bill for these services. And then there are wrinkles involving services that are provided over a 2-day period of time. And that happens a lot. I see this quite a bit. It's when you're talking about coding mistakes. So for an example, a continuous intravenous hydration is given from 11 p.m. to 2 a.m. In that case, instead of continuous infusion, the two administrations should be reported separately as initial 96374 and sequential 96376. And I see that coded incorrectly all the time. Improper reporting of injection codes. So only reporting one code for an entire session during which the injections take place instead of using multiple units of a code. This error, by the way, has been a top 10 RAC audit error. And the audit recoupment in the past few years, they're really hammering on this issue. If you have to use an unlisted code, you need to properly bill a service. You have to document it. I see a lot of practices say, well, it's unlisted, so I don't have to document it. Yes, you do. And most payers want to see that documentation. Now, sometimes it's not just about compliance. Sometimes it's just about the money, and we want to make sure that you're capturing that. So choosing the correct code can make a huge difference. Here's something in ENT where I have seen a loss of revenue from a procedure. So choosing a correct code here could make a difference of $50 for a physician. So you're attempting to distinguish a nasopharyngoscopy from laryngoscopy. Just remember this: what matters most in this area, the ENT examines, not where the physician inserts a scope. So when choosing between, and I have a problem saying this, so nasopharyngoscopy, okay, that's the 92511 code with endoscope, or the laryngoscopy 31575 code, that's a flexible fiber optic diagnostic scope. You should consider whether not whether the ENT introduces the scope through the mouth or the nose, as you might think. Instead, the key to proper coding is the anatomic area, the nasopharynx or the larynx, the ENT examines with the scope. So sometimes physicians choose to perform a nasal scope insertion for laryngoscopy because inserting the scope through the patient's nose is easier than making the patient hold open their mouth for a long time. And because going through the nose doesn't provoke the patient's gag reflex. So if you read nasal scope insertion in your physician's documentation and assume he or she performed a nasopharyngoscopy, you could be jumping to an incorrect conclusion. Remember that the 92511 reimburses higher than the 31575 in the non-facility setting. You've got a difference of 3.32 relative value units versus 1.91 RVUs, or about a $50 difference. So choosing the correct code has significant meaning to your bottom line. Make sure that you're reading your ENT's documentation very thoroughly to discern what anatomic part he or she is examining with the scope, and that fact should guide your selection. So, example, if the documentation states that the physician performed a nasal scope insertion and examined the interior of the patient's larynx, this provides a better view of the upper airway than traditional mirror exam, you would report 31575. If, however, the physician examines the nasopharynx, that is the attestation tubes, adenoids, and sphenoid, or the area where the pharynx and the nasal passages meet at the end of the hard palate, the correct code there is 92511. So it doesn't matter where the ENT introduces a scope, it's what they're looking at. And it's just really important that you also understand a little bit of anatomy there. One last example would be the diagnosis code K91.71, accidental intraoperative laceration of digestive system organ during procedure on digestive system. So when I see this coded, I always feel like I need to do a query, because coders are often overcoding or reporting when a physician documents that the laceration was expected, incidental, anticipated during a difficult lysis of adhesions. They're not always reporting or querying the MD for intraoperative lacerations due to clinical documentation, improvement, or other directives at the facility when apparently significant. So at the very least on this one, a query should be done on any questionable intraoperative lacerations as to whether they are truly complications or were they expected, because if they were expected or anticipated, it may not be something that you can bill for. And those are just some of the errors that I'm seeing recently that could definitely make or break your practice, and we just don't want that to happen. Okay, so my coding question today is interesting, and I haven't revisited this in a while, but I think it's important. So it says, Terry, I have a question on global days for procedures. I thought there was only a 90-day global that's out there. Now I'm finding there are global days and other global days, and I'm thinking it could be affecting my practice income. Can you clarify the global surgical days, please? Okay, so let's take a look at what that is. So there was actually a recent quiz done by AMA, and they quizzed coders and billers and regarding the NCCI and global fee periods. The most missed question was about the term 000, because you can look up a code and find out what the global days are on that code. So what this quiz was, it basically, one of the most missed questions said was the term 000 means in the global fee period listing. Almost 40% of the people taking the quiz marked it incorrectly, saying it means there's no global fee period. That's incorrect. There are 3 global fee period designations in the Medicare fee schedule. Okay, and so you want to make sure you take a look at that. 000 means the day of the procedure plus 0 additional days. So that means 1 global day. 010, so 0 to 10, that means the day of the procedure plus 10 additional days, 11 global days. And then the 90-day global, which is 090, the day before and the day of another 90 days and another 90 days. So 92 total global days. If a procedure has no global fee period, it is designated with an XXX in column 0 on the Medicare Physician's Fee Schedule RVU file. And so you have to make sure you're understanding the global days, because this means the service doesn't include any other services if you see that XXS. The 90-day, when we talk about the day before and the day and another 90 days after, this is important and vital for coders to understand, because if you provide a service within the global period, you may get a denial if you don't have a certain modifier saying that you're in the global period and you're returning to the OR, or this was a planned procedure, and they could reduce your reimbursement or not pay you at all. And so this is a huge income situation if you are not aware of your global services. So make sure you understand those files and understand how that works before you just make assumptions for things. So we don't want to assumptive code. Our coding question was brought to you today by Cadillac. Others talk about the road to success. We make cars for it. Cadillac.com. Make your way. Okay, so I wanted to end this week, and it looks like I got through it without too much coughing. I only had to stop a couple of times. But I wanted to, in the spirit of everybody kind of getting sick and when we're dealing with the coronavirus and all of that, it's about staying as healthy as you can and keeping your kids healthy. Just make sure you're washing your hands a few times a day. Think about things you're touching. You're coughing into your hand. You're holding food. You're holding your phone. You're holding money possibly, and that's the dirtiest thing out there. It's the culprit of most pink eye episodes. If you have access to any of those face masks that you're seeing them use all over the place, make sure that you take a look at one and try to use it if you have a persistent cough but are at the end of it. You may not be contagious, but it will make people around you feel better. Now, Amazon is actually out of them. There's a shortage of them because of all the ones they had to send to China. But check out a beauty supply store, the place where they get manicure supplies and stuff. I had to get a couple of packs there and have them shipped to a friend of mine who was visiting Hong Kong, and she can't leave because they're under quarantine right now. Drink lots of water. Make sure your kids and family are drinking lots of water, and do not share water bottles or straws. Your little kids are always wanting to, can I have a drink? Say no. Have them have their own cup, own utensils. Do not share food. Not right now. I mean, you shouldn't do it ever, but not right now. Once you're over the flu, or at least on the upswing, change out your toothbrush. Think about that and get grossed out like I do. Those germs are being put back in your mouth, and change out your kid's toothbrush as well. So be healthy and safe, everyone. Take these little steps to avoid lingering the flu. Also, happy Valentine's Day to everybody. That's coming up. It's Heart Disease Awareness Month, so wear red as often as you can to bring awareness to the public about heart disease and good health. And I'd also like to remind you of our listening platforms: Apple Podcasts, Spotify, YouTube, TuneIn, Google Play, Stitcher Radio, and our newest, Podbean. Charitable, which is a podcast charting. They just gave our year-end stats, and we ranked 18 out of 3,000 podcasts in the health and business industry. So thank you to everyone that has us now over 106,000 listens. So we appreciate you for sure. So on this Terry Tuesday, make it a great day and a great week. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.